Good evening to all. We are here to discuss on the topic of lymphadenectomy in ovarian cancer. To address the lymph node in ovarian cancers. The lymph nodes is one of the major pathways of spread in ovarian cancers. So when we see the all stages of FIGO after FIGO stages of ovary after systematic lymph node dissection, approximately 44 to 53% of the cases have lymph node involvement. When we go stage wise, we see in FIGO stage 1, the para-aortic lymph node involvement is 18%, whereas pelvic lymph node involvement is seen in 9% of the cases. If we go to stage 4, we see that the involvement of para-aortic lymph node is 66% and that of pelvic is 33%. So the pathways of lymphatic spread are shown in this figure. With the help of various dyes, we have come to the conclusion that the major lymphatic drainage was from the undersurface of ovary, then it ascends superiorly, predominantly along the superior ovarian pedicle, ovarian vascular pedicle. In the left, it travels through the left IP vein and drains in the left renal vein. Here, the high left infrarenal para-aortic lymph node often harbors the lymph node metastasis and is known as site of isolated recurrence. In right, the IP vein drains in the inferior vena cava, approximately 1 centimeter below the renal vessels. The lymph node, from there, the cancer cells pass along the lymphatic vessels covering the IVC. They come then drain into the interaortocaval space, and then from there, they travel to the lymph node at the base of the celiac axis. Uh, from there, the lymphatics travel via the cable openings in the diaphragm through the thoracic and reach the thoracic mediastinal and prescalene lymph nodes. The second lymphatic drainage is along the uterovarian ligament, where it travels along the lymph node in the broad ligament, along the external iliac artery, in the round ligament, and finally reaches the inguinal lymph node. Yet another minor lymph drainage occurs through internal iliac artery and reaches the obturator lymph. So now we come to the para-aortic lymph nodes. The para-aortic lymph nodes was first described by Fowler and Johnson, and they classified these para-aortic lymph nodes in 6 subgroups. The first one was pre-caval, retrocaval, interaortocaval, then pre-aortic, para-aortic, and retroaortic. The pre-aortic mainly drains the GI abdominal organs up to the mid-rectum, whereas the retrocaval and retroaortic have no role in no specific lymph draining sites. So the pelvic area is mostly drained by the para-caval, interaortocaval, and para-aortic regions. So they drain the iliac lymph node, in iliac lymph nodes, ovaries, and the other pelvic viscera. So these are important in gynecological cancers. There is another classification system for the para-aortic lymph node based on the assessment, how much assessment we do. The first is a systematic para-aortic lymph node dissection. A1 is complete assessment is done here. Along with suprarenal and infrarenal, both the para-aortic lymph nodes are removed. A2 is infrarenal only. A3 is infrarenal up to and just up to the inferior mesenteric artery. The type B is where the pelvic para-aortic lymph node sampling is done. B1 is extensive, B2 is minimal. And in C, we do not excise, we just assess. C1 is by palpation, and it is done directly. That is following the exposure of the para-aortic region. C2 is palpation is indirect. That is, we do not expose the lymph nodes. C3 is radiological assessment. Now comes the pelvic lymph nodes. Pelvic lymph node in ovarian cancers, we commonly address external iliac, internal iliac, obturator group of lymph nodes in pelvis. So the boundaries are superiorly by the bifurcation of the common iliac and laterally by the psoas and genitofemoral nerve, medially the paravesical space and the ureter, and caudally it is the origin of the deep circumflex iliac vein. So when we retract the external iliac artery, we are able to assess the obturator fossa, where we address the obturator group of lymph nodes. For obturator group of lymph nodes, the boundaries are cranially the common iliac artery, medially the paravesical space, ventrally there is a levator ani, laterally obturator interni, and caudally obturator. These are the approaches for transperitoneal approach to the paraaortic group of lymph nodes. The Komiyama maneuver is done to address the suprarenal paraaortic lymph nodes. And Kocha's maneuver is where we mobilize the second part of the duodenum to gain access to the IVC and the right side of the cable group of lymph node. Here we see the lymph node metastasis in ovarian cancers. The stage-wise involvement of the para-aortic and pelvic lymph nodes are seen, where in stage 1, 18, we have already discussed that the involvement is 9% is involved in pelvic and 18 in para-aortic. Whereas in stage 4, pelvic involvement is 33 and para-aortic is 66. Site, according to the site, when the disease is confined to the pelvis, the percentage of lymph nodes involved are 10 to 15%. When the disease spreads to abdomen, it is 64 to 67%. When one ovary is involved, ipsilateral pelvis involvement is 7% and ipsilateral aortic is 7%, both are 4%. According to the grade 1, 2, and 3. So in grade 1, there is 9% chance, grade 2, 7%, and grade 3, 32%. 32%. So clearly we can see that the risk of lymph node metastasis is dependent on the stage and histologic subtype. The early mucinous and low-grade endometrioid epithelial ovarian cancers have where the metastasis to the retroperitoneal lymph node was done by Philip Harter et al. In 2000. This was published in 2019. It is an RCT that was done from 2008 to 2012. 647 cases, advanced ovarian cancers patient was included, and intraoperative randomization was done. The inclusion criteria was advanced ovarian cancer, FIGO 2B to 4. Macroscopic complete resection was possible in these patients, and the lymph nodes were normal both before the surgery and during the surgery. They were randomized in two groups, lymph node dissection group and no lymph node dissection group. Primary endpoint was overall survival. Secondary endpoint was progression-free survival, quality of life, and number of resected lymph nodes. The median overall survival study was 69.2 in no lymph node dissection group and 65.5 in lymph node dissection group. Median PFS was 25.5 in both the groups, progression-free survival. Conclusion made was there was no benefit of overall survival or progression-free survival in lymph node dissection or no lymph node dissection group. On the contrary, we saw that there was high post-operative complications. Amongst these, the most important and statistically significant were the incidence of repeat laparotomies, where the incidence in lymph node dissection group was 12.4% and in no lymph node dissection it was 6.5, and the p-value for this was 0.01. The mortality, a 60-day mortality after surgery was 3.1% in lymphadenectomy group and 0.9% in no lymph node dissection group with the p-value of 0.04. This is the graph that shows the overall survival and progression-free survival, and it shows clearly that there is no difference between the two groups.
So what was the extent of lymph node dissection here in this trial?
Ma'am, it was a complete systematic lymph node dissection. That is, it was involving para-aortic as well as starting from the midpoint of the common iliac to the renal level, renal vessels level.
So infrarenal.
Yeah, infrarenal. Ma'am, it was, yes, ma'am, it was complete systematic examination was done.
Okay.
And on the contrary, the control group were having no lymph node dissection. Then there was another RCT that was done by Maggioni et al. It was done from 1991 to 2003. The main objective were to compare the proportion of patients with retroperitoneal lymph node involvement in between the two groups and assess the impact of systematic lymphadenectomy on progression-free survival and overall survival, and the complications related to the systematic lymph node dissection. The total number of patients were 268 with, but here what they did systematic lymphadenectomy in one in one group, and they did sampling in the control group. So the inclusion criteria here were early stage ovarian cancer, and there should be optimal debulking. There was the optimal debulking was included in these groups. So systematic lymphadenectomy detects higher proportion of patients with the metastatic lymph node. So it was 22 versus 9%. Lymph node involvement were more in grade 3 and serous histology. The 5-year overall survival was 81 and 84, respectively, in sampling and systematic lymphadenectomy, and 5-year progression-free survival was 73 and 78. Although there are minor benefits that we can see here, but these were not statistically significant. So the conclusion was systematic lymphadenectomy, when done in and high center surgical centers, it can be acceptable in early ovarian cancers. And it guarantees the optimal accuracy of staging and allows to tailor the post-operative treatment, whether to give adjuvant chemotherapy or not to give. The drawback was it was underpowered for survival. And increased use of chemotherapy was there in the study. So we could not assess the survival in this study. These are the graphs that show overall survival and progression-free survival in the study that shows that it is not statistically significant.
And this
Here,
chemotherapy was given in both the groups.
yes, ma'am, it was given in both the groups. So we could not assess what was affecting the progression-free survival and not the overall survival. So from here we also draw this inference that although the proportion of lymph node having mets was there more in the systematic lymphadenectomy group, and it was statistically significant, that is 0.002 p-value. Still, overall survival and progression-free survival was not different. So, lymphadenectomy, as per se, systematic lymphadenectomy could not be proved. Was not proved. Another study was done by Panisi et al. And was published in 2005. The study was carried from 1991 to 2003. The objective was to assess the role of systematic pelvic and periaortic lymphadenectomy in optimally debulk advanced ovarian cancers. 427 patients were included. They were randomized. And in one group, the systematic lymph node dissection was done, while in other, there was resection of bulky lymph nodes only. Inclusion criteria was the histologically proven cases, optimally debulked patients, stage 3B and 3C, advanced, and stage 4A if malignant pleural effusion alone was present in the patient. The primary endpoint studies were overall survival. Secondary endpoint was progression-free survival. The 5-year progression-free survival was 31 in the systematic lymphadenectomy group, whereas it was 21 in the control group, and with a hazard ratio of 0.76. So it shows that it increases the progression-free survival. Whereas for overall survival, it was 48.5% in systematic lymphadenectomy and 47% in control group. So there was no improvement in overall survival. These are the two graphs that shows this. The limitations of this study was 12 years they recruit the patients, and most of the patient had at least 63% had the residual disease that affected the survival outcome. The bulky nodes were dissected and the bulky lymph nodes were also dissected in the control group. So this diluted the study. And the discrepancy between the progression-free survival and the overall survival was also because the follow-up was not done. It was short, and different adjuvant chemotherapies were used. Second-line chemotherapy were used in the control group were different for different patients. Another study that was done by Delana et al. It was published in 2012. It was an RCT then from 1991 to 2001. The objective was to assess the role of systematic pelvic lymph node dissection and para-aortic lymph node dissection at second look surgeries. So 308 patients were included. Systematic lymph node dissection was done in first group, and resection of the bulky was done in other. Inclusion were the early stage or optimally debulked advanced ovarian cancers. Or optimally advanced ovarian cancers. FIGO 1A to 4 was included. Primary endpoint was overall survival. Secondary endpoint was surgical morbidity and progression-free survival. 5-year progression-free survival was 40 and 53 in the groups, and overall survival was same, respectively. The conclusion was systematic pelvic lymph node dissection and para-aortic lymph node dissection in second look surgery for advanced ovarian cancer did not improve the progression-free survival or overall survival. This now in summary, we can conclude all the RCT. In 2019, Harter et al. They showed that epithelial ovarian cancer in advanced cases with R0 resection, systematic and no lymph node dissection were the groups, and there was no benefit in OS and PFS. In Magani, there was they included epithelial ovarian cancer stage 1 and 2 with R1 resection, and systematic lymphadenectomy and sampling was done. There was no difference in OS and PFS. In Tennessee did in 2005, they included stage 3B and 4 patients with R1 resection. And they concluded that although there was progression-free survival benefit was there, but there was no benefit in overall survival. Delana did RCT on second look surgery, and they also did not find any benefit on overall survival and progression-free survival. This table tells us about various meta-analysis that was done to assess the efficiency of systematic lymphadenectomy in ovarian cancers. The first was done in 2020, published in 2020 by Quinglin et al. It was a meta-analysis that studied the above 4 RCTs. It was including both early and advanced. So the group were divided into systematic lymph node dissection, and in which the lymph node sampling was done. The progression-free survival and overall survival, there was no difference. Chiura et al. Did a meta-analysis. It was published in 2020. It included 3 RCTs and 11 cohort, including both early and advanced stages of ovaries. The groups were divided as lymph node dissection and no lymph node dissection. When we see the RCTs, we find that in early cases, in early ovarian cancers, there is some benefit in progression-free survival, whereas in overall survival, there is no benefit. When we see the RCTs for advanced, we see there is no difference in progression-free survival and overall survival. And when we combine these RCTs with the cohort, and then we see that there are some benefit in progression-free survival and overall survival. So another study was by Boyce et al. It also did 3 prospective multi-center trial analysis in advanced stages, and it showed that there was some benefit in overall survival. So when we see the RCT, we see that when we discuss RCT, we see that clearly there is no overall survival and some progression-free survival in early cases. But when we see the retrospective analysis and the cohort studies, then we see mixed studies are there.
Yeah.
These
Pragati,
yes,
go back to
yes,
the
sir.
slide.
Yes, sir.
Go back to You have to remember that in Chioda's meta-analysis,
Yes, sir.
basically the group where he says that there is no lymphadenectomy, it also includes people where sampling was done.
Yes,
So he
yes,
is
sir.
actually not clearly comparing the lymph node dissection with no lymph node dissection, but he
Yes,
is comparing lymph node dissection with sampling also.
exactly.
Because of
Yes,
the
sir.
3 RCTs, 2 RCTs are sampling
heart.
versus lymphadenectomy.
Yes, sir.
So how sampling is going to affect the overall result?
Ma'am, basically in sampling, they can improve, they can resect the bulky lymph nodes also and the suspicious lymph nodes also. Then it can affect the debulking. It is like doing debulking, which improves the survival. So it will dilute the control group. So it will affect the study.
So resecting, doing sampling, so to say, of these bulky nodes improves progression-free survival.
Ma'am, it does improve the, yes, ma'am,
Or it
Yes.
that yes, ma'am, it does because this is the study that this is the rationale for addressing in advanced ovarian cancer. That is the rationale for addressing lymph nodes that are bulky and suspicious because they reduce the residual tumor size, and that clearly has a survival benefit, ma'am.
So you basically are aiming for a R0 resection by removing the bulky nodes.
So these are various retrospective and SEER databases that were done, and they also found that Cheng et al. Was done in the year of 2020. It also compared the groups like lymph node dissection and no lymph node dissection. The number of patients included in both the groups were like, and there was no difference in the overall survival. So it was a negative study. Ting Deng et al. In 2021 was a retrospective study. It included stage 1A to 3A, and there was the groups were like lymph node dissection, no lymph node dissection, and there was no improvement in progression-free survival or overall survival. Slep et al. The study was done in 2019. That that was a retrospective analysis. There was some improvement in progression-free survival, but no benefit in overall survival was seen here. Oshita et al. There was found with retrospective analysis. There was no difference in the progression PFS and OS. Ebe et al. In 2010 did a retrospective study where they included early, advanced, and clear cell cancers. So in early, they found that there was improvement in progression-free survival and overall survival. And in advanced, there was no difference. Whereas in clear cell carcinomas, they clearly say that there was improvement in progression-free survival and overall survival with p-value of 0.046 and 0.01.
Dr. Pragati,
Yes, sir.
would you see this Arcelep et al. Study OS difference 92 versus 57? Is it non-significant? They are seeing?
Sir, this 92 and 57, basically it was not statistically significant because the p-value and hazard ratio was not statistically significant. That I have not included here. That but the study was negative only on OS, overall survival.
And Mainak, you have to also remember that includes stage 1 to stage 4 cases, and it is a non-randomized study. Could have been more early cases in one group versus the other. Selection bias.
Now there was another study to assess the lymph node metastasis in clear cell carcinoma. The 145 cases were included, and the conclusion was made that the cases where the ovarian surface involvement was there and positive cytology was there, there is 37.5% incidence of lymph node positivity with a p-value of 0.003. This study was done to assess the lymph node dissection in mucinous ovarian cancers. The objective was to describe the prevalence of lymph nodes metastasis in early mucinous ovarian cancers. Total number of patients included was 31. Lymph node dissection was, and no lymph node dissection was done. There was, in conclusion, there was after complete surgical staging, there was no effect on with lymphadenectomy. There was no effect on recurrence, degrees, and overall survival and disease-free progression in early stages of mucinous ovarian cancer. This study was done for early stage of malignant germ cell tumor of the OV. It was a SEER program. Objective was to assess the lymph node dissection survival benefit in stage 1. So in stage 1, hardly the lymph node came as positive, and there was no survival benefit. In sex cord stromal tumor also, there was a retrospective study. This was done with a total number of patients of 257, and the result was none had a positive lymph node. So in sex cord stromal tumors, we can go ahead with surgical staging without omitting the lymph node dissection. NCCN and ESGO guidelines on lymph node dissection in ovarian cancers. Now, when we have a newly diagnosed, apparently FIGO 1A and 2 ovarian cancers, para-aortic lymph node dissection and pelvic lymph node dissection should be done according to NCCN guidelines. Newly diagnosed cases involving pelvis and upper abdomen, only the suspicious or enlarged lymph nodes are resected. When we go for interval cytoreduction after neoadjuvant chemotherapy, suspicious or enlarged lymph nodes should be removed, and also the lymph node that were initially present with metastasis, and after NSCT they have regressed. We have to address them also. Mucinous histology on frozen section with no suspicious lymph node dissection can be omitted. Now, this study was done to assess the intraoperative and postoperative complication related to lymphadenectomy in ovarian cancers. It was a retrospective analysis, and objective was to assess intraoperative and postoperative complications. In group 1, lymph node dissection, a systematic lymph node dissection was done, and in group 2, no lymph node dissection was done. The result was intraoperative and postoperative complications was high in lymph node dissection group, but the postoperative complication was statistically significant. This chart states the same. The intraoperative complications were with the difference was p-value was 0.683, and the various complications were hemorrhage, urinary system damage, digestive tract damage, and postoperative complications were statistically more significant, of which the lymph edema and lymphocyst formation was most significant. Conclusion. Now we conclude the study with these evidences. The impact of surgical staging in epithelial ovarian cancer in early stages was first studied by Young et al. And he studied the 86 patient with disease that was apparently stage 1, that is grossly confined to OD. But after systematic lymph node dissection, the upstage was seen in 25 to 30% of the cases. And the most common site of involvement was para-aortic lymph node, that was 39%, then diaphragm 30%, omentum 25%, and peritoneum 26%. There was another trial also that was addressing the difference between adjuvant chemotherapy versus observation in early ovarian cancer after primary surgery. The two trials were ICON 1 and ACTION trial. The hazard ratio was 0.66, and here in ACTION it was 0.63. That means that the both trial were favoring adjuvant chemo to improve the recurrence-free interval. But in this case, in these studies, we could see that we could draw this inference that this can be because of wrongly involvement of stage 3 patients into the stage 1 patients. So this outcome was seen. Then there came the concept of stage of migration or Will Rogers phenomena. This states that changes in criteria for assigning patients to various stages of the diseases can produce spurious improvement in stage-specific prognosis, even though the outcome of individual patient has not changed. That means when we do systematic lymphadenectomy in early ovarian cancers, we can select the patients that are wrongly assigned as stage 1 and give them their stage upstage stage, that is stage 3 or 4. Then the prognosis of stage 1 or prognosis of stage 3, overall survival does not change, but we are now in a state to prognosticate the patients that your survival is according to stage 1 and so on. So systematic lymph node dissection in early ovarian cancer helps in assigning correct pathological stage for prognostic information, enables informed decision, need for neoadjuvant chemotherapy is there or not, and to curtail the treatment, that is if observation itself is sufficient, or to reduce the error of overtreatment. To reduce as per the action and icon trial, we should not go ahead and give chemotherapy to every stage 1 patients. Came the rationale for optimal debulking. In 1975, it was Griffith that stated that there is an inverse relationship between residual tumor size and survival. GOG 52 states increase in survival was there if the residual disease was less than 2 centimeter. Bristow et al. Stated that 10% increase in amount of cytoreduction increases median survival by 5.5%. Chi et al. Said both radical pelvic and extensive abdominal surgeries to decrease the residual tumor volume to less than 1 centimeter increases the overall survival from 43 to 54 months. Winter et al. Review GOG 111, 132, 152, 162, and they stated that even in stage 4, survival increases with complete resection, complete macroscopic resection. Now, AGO-OVR studies were there. The 3, 5, and 7 prospective phase 3 studies were there. They also state that even in stage 4, survival with complete resection is there. The GOG 182 also, they included 4,312 patients. This was to assess whether surgery to reduce the disease to microscopic was better, or addition of third drug to chemo, the 2 standard regimen chemo was better. They showed that when lymph node was positive with intraperitoneal disease of more than 2 centimeter, progression-free survival is 21. When lymph node is not there, negative with intraperitoneal disease of more than 2 centimeter, the PFS is 29 months. When lymph node is positive with preoperative intraperitoneal disease of less than 2 centimeter, the progression-free survival was 48 months. Also, Esenkov et al. In 23 studied the residual disease and its effects on median survival and 5% overall survival. So they also concluded that no visible disease has clear benefit in overall survival and median survival. So in advanced ovarian cancer, we address the lymph node by removing the enlarged, bulky, or suspicious lymph node as a part of tumor debulking. And retroperitoneal lymph node dissection or pelvic lymph node dissection can be done only when there is no macroscopic disease left after the surgery.
The question was not about whether to debulk adequately or no. I mean, if you see a node which is enlarged, you're supposed to remove it. That's not the question. It is the node which does not look enlarged or which looks normal. Should you remove that node or no? The question is that.
Sir, we should not remove that in advanced ovarian cancers. But yes, in early ovarian cancers, when we have to stage the disease, when we have to stage a patient, then we can go ahead with systematic lymph node dissection.
Okay, when the lymphatic drainage of ovary is only in para-aortic node, why do we address the pelvic nodes in these cases?
So basically, there are secondary lymphatic drainage also seen in ovary that involves the pelvic and the pelvic group of lymph nodes. But the primary lymphatic drainage is in the para-aortic lymph nodes only.
So that's fine. So that's what I'm saying. When you're doing it even for early disease, why are you addressing the pelvic nodes and not only the para-aortic node? What's the rationale of addressing the pelvic node, or why do you want to do a pelvic node dissection?
So because when the pelvic lymph nodes comes positive, then it states that the patient is stage 2, 2B, and the prognosis will not be as good as stage 1. and we can consider adjuvant chemotherapy.
No, that's not the reason for it.
Based on all these studies, they are saying in the stage 1, in FIGO stage 1, the OS, and the FIGO stage 3, the OS is like similar. How it can be, how the final diagnosis can be such? In stage 3, where the retroperitoneal lymph node is positive, they are saying there is no change in OS. So why there is upstaging of the disease if there is no change in OS?
To answer it, Pragati, it's a very interesting question. What happens
Sir,
when the disease is stage 2-3?
मतलब retroperitoneal lymph nodes are positive in stage 3.
You have a 1A patient.
Hmm.
You did a retroperitoneal lymph node dissection and you have upstaged the patient to 3.
Yes.
So what happens?
So the survival of that patient will not change. Only we can
No,
he will
but
be
your
stage
studies,
3 only.
but your studies are showing that there is no difference in survival.
There
Pragati,
is no
you have
difference
to
in
say
survival.
that because the patient has been upstage, stage for stage
Upstage.
survival is not different.
Yes,
No,
ma'am.
no, Malika, the reason is that when the disease is upstage, patient receives chemotherapy. In 1A and 3 with chemotherapy is nearly the same. That is what these studies are telling us.
So then, sir, we should routinely sample so that we should not miss this opportunity to upstage any stage 1A patients.
Yes. Then it's again the same phenomena. You do a lymphadenectomy, 39% are upstage and receives chemotherapy. 61% undergo unnecessary surgery. If you do not do it, then 100% receives chemotherapy, of which 39% would deserve it, and 60% will receive unnecessary chemotherapy.
So, sir, we consider every ovarian CA as stage 3 and give chemotherapy then.
That are the two trials which are telling you that after early disease, if you give chemotherapy, your progression-free survival improves.
Sir, in staging laparotomy, by the definition of staging laparotomy, we should routinely do retroperitoneal lymph node. That's the proper staging.
Yes, that is what the guideline says. That is what the guideline says. That's why she says that there is a chaos. This is one disease where the lymphadenectomy has not shown to have any effect on survival or progression-free survival in early disease, where it is recommended. But in later disease, where it is not recommended or it is done as debulking, it shows a progression-free survival if you remove all the disease or you achieve a R0 resection.
Sir, out here also I have a question, like the MSKCC CHI trial as well as the breast flow trial, where they are saying to go for CC0 as much as possible.
Yes.
Over there, they are also doing it for even the most advanced ovarian CA. Are they
Even
actually
stage
addressing?
4, even stage
Yes.
4, yes.
So are they extensively approaching those retroperitoneal lymph nodes also? That's my question. Whether their studies they say that
Yes.
yes.
Yes, debulking means leaving no disease behind.
However, all the rest of the studies are saying even if you leave behind the nodes, there is no change in OS. You can leave behind nodes, just do CC
I
properly,
think
and
I think I think you have to show him the slide on debulking where you have talked about lymph node positive and debulk, lymph node negative and debulked, and let him see that slide. Yeah, that's it. Now see what happens when you have lymph node positive and you don't optimally debulk, and see when you have lymph node negative and you optimally debulk.
when we are
See
optimally debulked and
see the first and the third line. Lymph node positive, optimally debulked, lymph node positive, not optimally debulked. See the difference.
and so last line lymph node positive with optimal debulk has a better PFS.
That's exactly what I'm asking you to look at.
So that means we
That
can
is
leave
what I'm
behind lymph
asking.
node.
That is what I'm asking you to look at. So if you look at the first and the second, lymph node negative, not optimally debulked, lymph node positive, not optimally debulked. Survival is same.
Yes.
When you look at lymph node positive, not optimally debulked versus lymph node positive, optimally debulked, you see the difference in survival.
Yes. Yes. Yes.
So it
So
is not
having
the lymph node positivity that is mattering. What is
lymph node.
mattering is that how much disease you are leaving behind. So where you leave
So
the disease doesn't matter. How much disease you leave behind matters.
in a nutshell, having positive lymph node actually doesn't matter.
That's what the studies are actually showing. If you can take it out, if you take it out, if it is positive, you take it out. you optimally debulk, and all these patients would receive chemotherapy. So anything more than 2A would receive chemotherapy.
Sir, as we have seen in C endometrium, where sentinel lymph node has becoming very popular, sir. Like in early ovarian cancer, like any role of sentinel lymph node biopsy, like are there
Pragati will
any role?
answer. Pragati will answer it.
Sir, there are some studies are there, retrospective studies are only there for assessment of sentinel lymph node in early ovarian cancers. But in that studies, there was the lymph node dissection was completed. There was, but the lymph node metastases were not found in any of the lymph nodes. So still now, these studies are on trial whether the lymph nodes assessed by addressed by sentinel lymph node are of any help, can be of any help or not.
Like the thing is, should we do lymphadenectomy or not in early? So as an alternative, sentinel lymph node can be used, like just like in any other cancer we treat. The question is, should we do or not in early? The big question. Why can't we replace it with sentinel, just like in any other cancer? Like,
Keshav,
why is it
Keshav,
not being
I
popular?
want you to
Yes,
give
sir.
the
Yes,
answer.
sir.
What are the difficulties in doing a sentinel lymph node in an ovary?
Sir, I've seen a like a review article, sir. It's a very old article, like they have studied for from 1991 to 2019, sir, where they have found in some 3 to 4 sites of injection, like in pelvic ligament and ovarian hilum, like 2 3 sites. They have found a reasonable site to identify the sentinel node, sir. They found it effective, but not many studies were done, sir. Like I
Yes,
could not see many
because
studies
because
done.
because the problem in ovary is that if you inject it peritumorally,
Yes, sir.
you upstage is
Capsule, it can have
which
uh,
Surgical
one
hospital,
C,
each.
1C1.
1C.
Yes, sir. Yes, sir.
So you have to inject either in the around the ovarian pedicle
Yes,
or
sir.
the uterovarian ligament.
Yes, sir. Two ligaments.
There are
Yeah.
only two places where you can inject it. So they actually do not represent the true lymphatic drainage of the tumor, and that is why in this ovarian the sentinel has not been able to pick up. There are studies, people are still doing it, people are trying it.
Yes, sir.
But then they have identified sentinel lymph node, but none of the cases the sentinel lymph node has been found positive in so far. So that is one of the problems that people are having in
Yes.
early ovarian cancer, where
Early on.
it can help.
Yes,
And
sir.
Pragati, what is the role of MIS in early ovarian cancer?
Minimally invasive, ma'am, in early ovarian cancer, when, ma'am, the imaging is definite that it is that it is confined to one ipsilateral ovary, and the age of the patient is less, and then accordingly we can do minimally invasive surgery and do comprehensive staging with minimally invasive surgeries also, ma'am. We can take go ahead and do the lymphadenectomies also, and lymph node sampling at least, and then we can stage the patient with minimally invasive surgeries also.
So what happens if the tumor ruptures?
It will be said 1C2. Upstaging will occur.
That is why minimal invasive surgery is not recommended if you are suspecting a malignant ovarian neoplasm.